amount of time. Introduce her. So Dr. Shannique Richards, she is a licensed clinical psychologist and instructor in medical psychology and psychiatry. She's a member of our Women's Reproductive Mental Health or WORM program here. Dr. Richards received her doctorate in clinical psychology from the City University of New York City, City College. And then she completed her pre-doctoral internship and postdoctoral fellowship at Lenox Hill Hospital's Department of Psychiatry with specialized training in reproductive mental health. And then Dr. Richards has expertise in the perinatal period, trauma, and stress-related issues. And then we're excited to have her join us today to give a presentation on coping with fertility-related grief and loss, a relational approach. So without further ado, I'll welcome in Dr. Richards. Thanks again.
Thank you, Nicole, for that very kind introduction. I will attempt to share my screen and get us started. Let's see. Can everyone see my screen? Yeah? Okay, perfect. All right, so as Nicole mentioned, I'm Shannique Richards. I'm a licensed clinical psychologist here within the WORM program, as well as an instructor in medical psychiatry, medical psychology and psychiatry. And I'm here to talk to you today about coping with fertility-related grief and loss from a relational perspective. I know this topic can be a little bit heavy, and so please do what you need to do to take care of yourself. No financial disclosures, not to disclose. So today I hope to be able to describe the unique psychological, emotional, and social challenges associated with fertility and pregnancy loss. Discussing some ways grief is expressed and processed, particularly in that perinatal period, and to discuss, some therapeutic strategies from a relational perspective for coping with perinatal grief and loss. I wanted to say, as Nicole mentioned earlier, that I arrived in this area during my graduate and fellowship training, where I work primarily with women in different stages of their life. So I've heard countless stories from women who are in preconception stages, considering parenthood, those who society continually reminds them of their biological clock, those who have had prior pregnancies and losses, and those also going through fertility treatment. And one of the recurring themes in many of these clinical cases, at least from my perspective, was that there was some aspect of grief and loss that was unlike the type of grieving process that I was exposed to, right? And I would also say that one of the things I struggled with in putting together this presentation was how to acknowledge, a range of identities and complexities as opposed, and I'm realizing that I'm not able to do everything. And so you may be hearing me say terms like woman, female, she, and her. And I want to acknowledge that not all birthing people identify as female. And although I may be using these gender terms, gender is on a continuum. And I'm still thinking about ways to make presentations like this one more gender expansive. Nicole, if I can ask, when we get to talking about clinical material, can I ask the recording to be paused? Because I want to protect clinical material. Yeah, okay. So I want us to start off with a story today. If the story, I've taken great steps to identify later. Thank you.
That was me.
Thank you. Yeah, so I wanted to start off with a story. I've taken great steps to identify this information. And so if the story looks familiar, chances are it's because you may know of someone who has struggled with something very similar. So I'd like to make this a little bit more interactive. If there's somebody who would like to read Mrs. M's story, that would be great.
Mrs. M is a single cisgender woman in her late 30s who presented to psychotherapy with symptoms of sadness, hopelessness, low motivation, minimal interest or pleasure in activities, social withdrawal, and hypersomnia. Mrs. M reported a history of pregnancy loss, which she experienced as traumatic and which was contributing to her distress. Mrs. M pursued fertility treatments, including multiple rounds of intrauterine inseminations and in vitro fertilization cycles, all of which were successful. These experiences intensified her feelings of grief, isolation, and personal failure. Ms. M also has a history of developmental trauma, which has long-standing patterns of avoidance, heightened fear of abandonment in relationships, and a pervasive sense of lacking control.
Thank you so much. So I'd like you to keep Mrs. M's story in mind as we go through this presentation. We'll come right back around to it at a later time. So I'd first get us started with talking about, infertility and the significance of it. The World Health Organization has acknowledged that this is an area that could benefit from more research, especially as 1 in 6 individuals of reproductive age are impacted or is impacted by infertility, with as many as 48 million couples and greater than 186 million people worldwide are affected. And infertility affects about 10 to 15% of couples and is common between the ages of 20 to 45 years old. And with that said, approximately 85% of individuals and couples with no fertility issues conceive within 1 year of trying, but about 56% of those who are trying to conceive tend to seek medical assistance. And for those struggling with infertility, it can certainly take a toll on one's mental, emotional, spiritual, financial health, and contribute to symptoms of depression, anxiety, and post-traumatic stress disorder. So I want to provide a definition for infertility according to the American Society of Reproductive Medicine. It is a condition characterized by the inability to achieve a successful clinical pregnancy or failure to carry a clinical pregnancy to term based on one's medical, sexual, reproductive history, age, physical findings, as well as a combination of factors. And so if you're under age 35 and you've been having regular unprotected sex for 1 year and have not been able to achieve a successful clinical pregnancy, it's recommended to seek an evaluation. Similarly, if one is over 35 years and is not able to achieve a successful clinical pregnancy after unprotected intercourse for 6 months, it's also required to get an evaluation. Or recommended. And there are 2 different types of infertility, right? So there's primary infertility, where an individual or couple has never had a successful clinical pregnancy, but is having difficulties conceiving. And then there's a secondary infertility, which is where there's a history of an established clinical pregnancy, but there might be some difficulties conceiving again. So what are the causes of infertility? Well, there are several causes, right, including male factor infertility, which accounts for 1/3 of infertility cases, which may be due to sperm problems caused by things like trauma, diabetes, sexually transmitted diseases, obesity. Might also be related to hormonal disorders or genetic disorders. 1/3 of the cases also attributed to female factor, right? And so that might be due to ovulation problems such as polycystic ovarian syndrome, hormonal imbalance, obesity, or low ovarian reserve. And then things like, tubal blockage, like endometriosis or sexually transmitted diseases, as well as uterine problems can contribute to female factor. And then about a number of cases are unexplained, right? So you're unsure what is contributing to the infertility. And about 10 to 20% of couples tend to have what we call unexplained infertility. Looking at psychiatric disorders in infertility, infertility can contribute to a number of psychiatric factors, including major depression. Some factors contributing to that include like societal pressures to have children or gender roles, depending on one's culture, right? Major depression can also be related to how one is judging of oneself, or the inability to conceive, or the feelings of failure, right? Coping mechanisms, right, may also play a role in the development or the maintenance of depression, a feeling of helplessness or loss of control, whether or not the individual is able to accept the reality of their circumstances. We also see that about 23.3% of women report generalized anxiety disorder. And then studies have found about 41.3% of infertile women had post-traumatic stress disorder symptoms. And so I'm going to switch our attention a little bit to talking about, before that, the psychosocial impact of infertility. So like there's the psychological and the social. Psychologically, feelings of frustration, feelings of inferiority, feelings of guilt, betrayal. Oftentimes, in my work, I've seen body betrayal can contribute to sort of like this psychological impact. And then we also see the social piece, right, which can play a significant role, right? So if it can impact or strain relationships, especially if partners cope differently. Friendships, maybe it's seeing one's friends being able to get pregnant while we've been struggling to conceive, and that can contribute to feelings of envy, right? Some individuals may withdraw or isolate, and it can also contribute to diminished sexual pleasure, intimacy, especially, when couples maybe have the time when they engage in sexual activity. So that can be certainly impactful. So I'm going to switch our attention a little bit to talking about pregnancy loss. It is not uncommon for a woman who experience infertility to also experience pregnancy loss. Pregnancy loss occurs in about 25% of pregnancies, right? There are different types of pregnancy loss. So we have miscarriage or spontaneous abortion, which is defined as an unintended termination of pregnancy before 24 weeks of gestation. And studies have found at least 15 to 25% of all pregnancies end in miscarriage. Stillbirth, 2% of pregnancies end in stillbirth and is defined as the death of a fetus after 24 weeks gestation. We also see neonatal death, which is the demise of a fetus in late pregnancy. We also have termination of the pregnancy for fetal anomaly. And the reason why I put an asterisk there was because this is, heavily stigmatized. Oftentimes it's because it's being seen as making that choice to terminate. And then we have recurrent pregnancy loss, which is 2 to 3 consecutive losses of pregnancies, which is common in about 2 to 6% of the general population. Pregnancy loss has a significant psychological impact on women, where studies have found loss has impacts on increased depression, as well as short-term anxiety. And as it relates to the depression piece, depression is oftentimes confused with grief, which we'll talk a little bit more about. So it's important for providers and clinicians to distinguish depression from normal grief reactions. Like I mentioned, some studies report at least 20 to 40% of anxiety as it relates to pregnancy loss. There's a large meta-analysis of women that found large and significant effect of prior pregnancy loss on anxiety, especially in future pregnancies. Recent studies have been showing 10 to 45% of women who experience loss show symptoms of post-traumatic stress disorder. Some of these studies show that bereaved women are 7 times at risk for PTSD. And the risk is sort of increased if there's a history of previous psychiatric conditions, or maybe there's no living children, there's a lack of support, if the individual feel they're responsible for the loss, or if they're struggling with infertility. And then we also found studies have been, find at least 4% of their sample reported substance use disorders as perhaps as a way to cope with loss. And then pregnancy loss has been shown to contribute to, complicated grief reactions as well. So taken together, infertility and pregnancy loss are reproductive traumas, and it is not uncommon to experience both infertility as well as pregnancy loss. I'd say that infertility and pregnancy loss can trigger prior traumatic experiences, including adverse childhood experiences. It can reactivate unresolved prior losses, including the death of loved ones. It can increase risk for perinatal mood and anxiety disorders, especially if there's a pregnancy established after infertility or pregnancy loss. And it can contribute to complicated grief reactions or grief reactions in general. So I want us to shift to, talking about grief, particularly as it relates to infertility and pregnancy loss. And I have to say that grief behaviors vary or reactions vary, right? And so interpersonally, societally, that just might look a little bit different, right? And so there are these tensions about how to grieve interpersonally. What are these social expectations around grief, how grief shows up intergenerationally, how families acknowledge grief and loss, right? How cultures acknowledge and not acknowledge the grief, right? A woman, for example, being given time off to process this loss. Medically, how is information conveyed around loss that might also impact the grieving process? So a lot of pieces to kind of hold in mind there. So I would, start us off by saying grief is a normal reaction to loss, right? The usual course of grief is not experienced by every individual in the same way, and for some, it can be absent, delayed, or prolonged. I'm sure many of you are familiar with Kubler-Ross's stages of grief, like the denial, the anger, the depression, bargaining, and acceptance. Well, expectations may actually look different from reality, right? So some individuals struggling with reproductive loss might move in and out of these stages without a particular order. So maybe someone with infertility has, come to terms with the fact that they may have to consider, using donor X, right? And 2 months later, a friend becomes pregnant and now they're moving back to that angry stage, right? Or maybe it's an individual who have had a miscarriage around the holidays and has worked through sort of like that depression stage. But this year during the holidays, you start hearing things, but maybe if I didn't lift that heavy object, I would have had a 1-year-old right now, right? So like just like how much that it's entirely possible to revert to previous grief stages. And for that reason, grief is not linear. So rather than this perfect looking graph, you might just have this. So I want to look at the different types of grief that one can experience in the infertility and pregnancy loss journey, where we see prospective grief, which is where fantasies or hopes for a pregnancy or a baby or an imagined future is mourned. But I really want to pay attention to disenfranchised grief, which is very common amongst individuals struggling with infertility and pregnancy loss. Unlike, the death of a loved one, which might include rituals like a funeral or a wake, with infertility and pregnancy loss, these kinds of loss do not have public recognition and are likely to be ignored. And this lack of recognition can compound the grief reactions and contribute to feelings of isolation. We also have traumatic grief, which is where grief that occurs as a result of a death of a loved one together with an unexpected and distressing event, right? So early or late pregnancy loss can contribute to traumatic grief. Similarly, as with infertility, each month a pregnancy test comes back negative. It's almost like mini deaths, right? Especially when we think about going through things like infertility treatments, right? And those can be experienced as traumatic. And then we have complicated grief, which is a prolonged state of grief with significant impairments in social, occupational, and important areas of functioning. And we tend to see this more commonly associated, with pregnancy loss. And some of the risk factors for complicated grief included, a lack of social support, ambivalence about the pregnancy, maybe pre-loss major depression, and if one has to terminate a pregnancy due to fetal anomaly. So I want us to, as I mentioned earlier on, grief depression is oftentimes confused with grief. So I thought it might be helpful to maybe look at some differentiating factors as proposed by Wolfelt. It is, possible to experience normal grief reactions and depression symptoms. And sometimes normal grief reactions can develop into clinical depression. And so that can also inhibit, one's ability to grieve. And so someone who is experiencing normal grief reactions may be able to openly express anger, respond to comfort and support, able to relate their depressed feelings to the loss experience, maybe exhibit feelings of sadness and emptiness, can still experience moments of enjoyment in life. They can express guilt about something about the specific aspects of the loss, maybe reporting some transient physical symptoms and feel a temporary loss of self-esteem, versus with clinical depression, I oftentimes see like irritability and complaint, but maybe not a direct expression of anger or an unwillingness to accept support. Maybe do not feel maybe sort of like the expression of feelings is not it's not specific to a particular life event, right? So more general, a projected sense of
You're needed to the front desk.
hopelessness and chronic emptiness. This all-pervading sense of doom, generalized feeling of guilt, chronic complaints, feel a deep and ongoing loss of self-esteem. I want to say, though, that the boundaries are a bit blurry between the depression as well as normal grief reaction. And it's really important to kind of distinguish, not just distinguish, but be mindful of that. Because oftentimes when we think about the blurred boundaries, like people maybe who are having these normal grief reactions might come into treatment. And especially in westernized societies, you're sort of having to give a diagnosis in order to be treated, right? And so in some ways that grief reactions can sometimes become, pathologized, but grief is not a disorder. Right, and in terms of like that tension of sitting with it, an article written by ISMA in 2023 proposed sort of like looking at the duration and severity as indicators for distinguishing normal versus prolonged or complicated grief. So I'll look at common grief reactions, and I've sort of like broken them down into these 4 different categories, right? So there's the feelings, right? Individuals might express feelings, so that might look like shock or this denial, this feeling of helplessness, anger, sadness, anxiety. Maybe they report loneliness, this sense of yearning, guilt. Might see sort of like that move. That might also look, cognitively, right, as ruminations, right, intrusive images or thoughts, the sense of disbelief or confusion. It might show up somatically as headaches, tightness in one's chest, maybe difficulty sleeping, hypersomnia, loss of appetite, sexual issues, right? And then it can also show up behaviorally, right? So maybe there's an avoidance, or increased tearfulness, maybe there's a withdrawal or isolation, and sometimes that might also look like reactivity. Okay, as I mentioned earlier, people grieve in different ways, and there are different ways to think about grief, but there are also these stereotypes around how men and women tend to grieve. And while gender may impact how people grieve, it's also important to recognize that grief can be expressed in different ways, a variety of ways, and people can actually go between the different ways in which they cope. So Martin and Doka developed some approaches to think about this, to combat this stereotype, right? So sort of like proposing intuitive grieving versus instrumental grieving, right? So intuitive grieving, like this outward expression of grief, right? That might look like tearfulness, crying, lamenting, difficulties concentrating, feeling disorganized or confused, or physical exhaustion. And then we have the instrumental grieving, which is perceived as, less intense, more cognitive, and there's a reliance on problem solving. And important to hold these pieces in mind too. And like I said, individuals can kind of go through both styles of grieving. And so sometimes when you're having conversations with your patients, sometimes they might report, like, yeah, I wanted to express myself, but this family member, they just wanted to give me resources, right? And so like to also provide some education around like different grieving styles, and just like how that might look differently for different people. So when we talk about infertility, I'm going to spend a little bit of time here. Individuals are experiencing a particular type of loss, right? And so Jaffe and Diamond propose some ways in which we can think about this loss. And so there's a loss of an experience of pregnancy and birth, right? When we think about, pregnancy, it is an embodied and a transformative experience, right? A lot of this work coming out of the work of Arlie Ethan, right? Sort of like this is a part of one's reproductive identity. And each month, a period is a reminder that you're not pregnant, right? So not only is there no baby that is longed for, there's an absence of the physical ability to experience pregnancy and birth. There's a loss of sense of belonging, right? I tend to hear hear this among individuals who may no longer feel connected to their friends, who can conceive successfully, or feel like a misfit in society, or their sense of community is threatened. It's a loss of control, whether it's body, around the body, the life, or the narrative, right? And this is very common sense of loss that I hear oftentimes in women that report that their bodies are quote unquote not functioning as it should, right? So they feel like they have failed, and also feel a sense of helplessness. As a loss of, feeling healthy and normal, right? So having to go to the doctor's office, especially if one is seeking out medical treatments for infertility, challenges the notion of what it means to be healthy. As a loss of feelings of competency. So I often see this particularly among individuals who are high achieving. And this is one area maybe that they are not, that is not as successful. And so they tend to feel like this sense of incompetence. There's a loss of sexual intimacy, right? So infertility can interfere with desire, spontaneity, enjoyment. It can also put a strain on relationship, and it's also another reminder of the loss, right? We also see the loss of hopes and dreams, right? Everybody has a reproductive story. How you came into this world, maybe if you're also trying to start a family, right? There is a reproductive story. And so whether it's a story, just like, sort of thinking about like how infertility can challenge this story that one has and sort of like shift just like the narrative around that. And then lastly, like the loss of identity, right? So infertility can challenge one's sense of self. When it comes to grief, women are also mourning who they were before infertility and who they are at present as someone struggling with, infertility. And then as it relates to grief and loss, a part, so Jaffe and Diamond also talks about like, a part of the mother has died, right? So there's a loss of essential aspects of one's identity. And this identity around what it means to be a parent can be experienced as stolen, right? Grieving parents are also forced to mourn at the same time. They're making sense of the trauma of the loss, which can be a lot. And they're also processing the loss of a life yet to be lived. And then there's this loss of belongingness and status within society, especially if culturally, if you're pregnant, like how people see is that the expecting pregnant person, whereas, when there's no baby, it's almost like you're seen in a different way, right? And so there's a lot of losses there. And then particularly as we think about the current socio-political landscape, I felt like it's important to say something about that, right? Where pregnancy losses can be criminalized in some states, and that can further add to the complicate the grieving process, right? So an author, Golzar Nakshina, wrote an article that's currently in press that talks about like how shame and ambivalence sort of like are compounded, right? So as it relates to the shame piece, right, in the context of loss, that can become heightened in the current political climate that is sort of like against reproductive autonomy, right? So in addition to the unacknowledged grief and pain associated with the loss from becoming pregnant, shame is also used as a weapon, because especially when that loss is criminalized. And then as it relates to ambivalence, right? There's always some ambivalence in pregnancy, which is healthy. But in cases where there's forced pregnancies, even after a loss or the establishment or expansion of personhood to fetus, that can increase, mortality and even risk persecution, right? It only heighten the intensity and the experience of loss. All right, so I want to talk about what some of the behaviors are that facilitate grief. One engagement in self-care, including, diet, getting adequate amounts of sleep, right? Practicing mindfulness, humor, one's being in community with supportive individuals, level of acceptance, right? Those are all ways in which it can facilitate grief, right? And I also want to talk about post-traumatic growth, right? It's one's ability to hold on to profound states of sadness of grief, while also recognizing the transformation that grief and loss may bring in the process, right? So maybe there's one might experience an increased ability to cope with adversity, or maybe it might bring a couple closer, right? And maybe it might just one's faith or religion might just, might open some more doors there, right? So how can we also hold space for both the loss, but also like what can some of the outcomes be as well here? And then some of the behaviors that disrupt coping, which is like avoidance, denial, guilt, self-blame, which we tend to see guilt and self-blame are what we tend to call secondary emotions, and it's not, and oftentimes see those as not necessarily as adaptive in terms of coping, and it's not like the individual want to go to what guilt or self-blame. It just might be more accessible, right? And so what is the guilt sort of like? What is that at the top? What is below that guilt, right? Is it the sadness, right? So really wanted to understand what the primary feelings are. And hopelessness can also disrupt coping, using substances as a way to escape, one's experience. And so I want to sort of switch to talking about sort of like that third objective, which is that relational approach. I would say that very little attention is paid to a relational aspect of grief. And it's one where the relationship with the therapist offers a space to grieve what is lost. And I love this quote from Raina Markin, and she says, grief needs to speak, but it also needs an understanding and supportive other to listen, right? And so as we think about, infertility and pregnancy loss, right? So the therapeutic relationship may play an essential role in promoting positive outcomes in psychotherapy. One of the things that it does is provides a space for the individual to have support and understanding. Pregnancy loss and infertility can impact one's self-esteem, right? And the hope is for the relationship with the therapist to help with restoring some of that, self-esteem that is lost. The therapy relationship can be an effective and regulating space, especially in revisiting early adverse attachment experiences that may be contributing to the difficulty in processing the loss. The therapy relationship also helps with building a secure attachment with the therapist. It allows for safety in the processing of trauma and loss. Kind of going back to that piece a little bit, like there's some conflicts around like, whether somebody is secure versus insecurely attached, like, can they benefit both from that therapeutic relationship? And still there's some contention there. And while there's benefit to, individuals who have a secure attachment, those with an insecure attachment tend to really benefit from that. And the therapeutic relationship, also goes beyond crisis intervention and interventions that target immediate relief. And those are incredibly important to have. But also using the therapy as a space to explore unresolved feelings of trauma and loss, which can help with rebuilding the impact of the loss in one's sense of self. As you notice, I've highlighted attachment because it comes up twice. And so I want us to focus on attachment as a way of thinking about, how to help individuals kind of cope through infertility and pregnancy loss. So attachment theory, pioneered by Bowlby, offers a useful, framework for working through grief associated with infertility and pregnancy loss. The premise is that as adults, we tend to relate to the world in similar ways. We relate to our caregivers or attachment figures during childhood. And according to grief theorists, the ways of relating can be carried over into the way people cope, when they experience loss. And early attachment experiences with attachment figures can provide an internal model working model for one's sense of worthiness and whether or not they're worthy of seeking care and support from others. One's early attachment may play a role in the development of a sense of self-worth, whether or not the individuals seek out help or not seek out help, how they relate to other people, and our expectations for feeling valued, right? And as it relates to pregnancy loss, this can be understood as a loss of an attachment object, right? And according to Bowlby, similarly, attachment behaviors that are employed during childhood when distressed, right, which can, pregnancy loss can be distressing, that can be reactivated and responded to in similar ways. Similar for infertility distress, but what I've been finding, at least in my own research around this area, is that there are limited studies on attachment dimensions and infertility related stress. So definitely some areas to be worked on there. And so I want to talk about attachment as it relates to infertility and recurrent pregnancy loss. The stress of infertility in combination with recurrent pregnancy loss can trigger one's attachment system, right? It can threaten the attachment for a longed-for outcome, and attachment can take place even without a pregnancy. Sorry, perhaps there's an attachment to the anticipated pregnancy. So when we think about, like, for example, let's say an individual or couple who sought out medical assistance for infertility, and maybe they made some embryos, and maybe an embryo was implanted during by in vitro fertilization, and that was unsuccessful, right? That is also a mini death, right? And so the individual can mourn the attachment to the anticipated pregnancy. And so clinicians have to also factor in the meaning also too of the pregnancy or hoped for pregnancy, as it may determine sort of like the intensity of the attachment. All right, and so you want to inquire about, readiness for pregnancy, talking about the responsibility of parenting. So just kind of having a conversation about that can help you sort of think about like what, the attachment to the anticipated pregnancy or the pregnancy could look like. So from an attachment relational perspective, distress associated with infertility and pregnancy loss can trigger one's attachment system and invoke earlier experiences with attachment figures, including a prior history of traumatic losses. So what are the goals of therapy, right? The goals of therapy is to be able to utilize a therapy relationship as a mechanism for processing loss and trauma, restoring one's healthy sense of self, developing a more secure attachment through one's internal, working models, right? And so it's incredibly important to validate some of these experiences, right? So though family and friends and concerned individuals may be well-meaning, saying things like, get over it, or at least you have one other child, right? Like these things, while they might be well-intentioned, they can come across as invalidating. And so having a space to be able to normalize these experiences just is vital. What are the tasks associated, right? So Bowlby talks about these attachment tasks, for a therapist to sort of pay attention to, right? Do you want to establish a secure base for the individuals to be able to safely explore, right? And the goal is for this to help with promoting and processing the losses, as well as other reproductive events. We want to explore past attachment experiences, right? So that might look like parental figures or grandparents, might look like uncles, right? Or past as well as present relationships. You also want to explore the therapeutic relationship, like, what's going on in the room between you and the patient. Maybe the patient is telling you how they're worried about being abandoned by a parental figure. How is that showing up in the room between you and the patient, right? Are they also wondering if you might be abandoning them as well? I want to link past experiences to the current, right? So how did they process the loss? Let's say there was a loved one who passed away. How did they process that? Is that similar to the way in which they're processing the current experience of grief and loss? And you also want to revise, internal working models, right? So what schemas did they come up with due to past experiences that might be getting in the way of grieving? Did they learn that they only had a limited time frame, 5 minutes to cry before they need to get over something, right? Or maybe, only some emotions are acceptable and not some, right? And so how is also that showing up in the therapy space? And so we want to rework some of those earlier internal models to create different ones. Okay, so I also want to look at, some other therapeutic elements, right? So for us to consider, especially when we're thinking about relational therapy, therapeutic alliance, right? That oftentimes research has shown time and time again that therapeutic alliance predict psychotherapy outcomes, right? And one aspect that that impact the therapeutic alliance is the therapist attachment style, right? Relational therapy requires the therapist to know also thyself, right? What things are activating in the room with the patient for you. For a therapist, let's say with more avoidant attachment styles, do you notice you're more inclined to collude with the patient? Around talking about the grief. So you want to talk about everything else but the grief, right? What feels easier to validate and empathize versus what feels harder, right? So kind of really just knowing what that process is for you. Utilizing also sort of thinking about, the certain topics, right? Also activate your own attachment system as a therapist, right? So it's talking about a miscarriage or upsetting to you. And relational therapy also requires the use of here and now, right? Using the relationship as a vessel. Again, so it's what's going on in the room between the patient and the client, patient and the therapist, right? This does not mean always sort of like focusing on the therapy relationship. Maybe you're working in interventions, but you're also occasionally wondering what's going on in the room between both of you. Rupture and repair is central to the relational process, and it helps with revising attachment patterns or process unresolved attachment issues that may interfere with the grieving process. So maybe there is a rupture about what the client wants to talk about versus what the patient actually wants to talk about, or maybe the therapist uses an insensitive word that triggers one's attachment system, and the relationship can be used as a way to process that rupture in a different way that they had experienced with their primary attachment figures. And then lastly, Safran and Moran talks about sort of like the elements of resolution, like coming to a resolution around rupture and repair, which includes a therapist identifying and drawing attention to the rupture, right? Exploring the feelings connected to the rupture, exploring the patient fears and expectations that might be interfering with the process, and maybe exploring, any underlying wishes the patient might have. So I also want to touch briefly on just attachment and continued bonds, right? As mentioned earlier, infertility and pregnancy loss, they are disenfranchised. And so Bowlby talks about continued bonds model, which considers the role of attachment and offers a way to be connected to the loss and form a new relationship based on the memories or an internal connection, right? And so one of the ways we can achieve this is by creating mourning rituals, right? Talking to your patients about, ways in which we can kind of hold on to some of these losses, right? And so it's not uncommon, again, for individuals to experience both infertility and pregnancy loss. So some of what I'm listing here can also be used interchangeably, right? And so for pregnancy loss, I'm thinking about do you want to plant a tree? Coming up with ideas to memorialize this loss or create that ritual, right? So did the baby have a name, right? Can that also be named in the room? Creating a memory box, holding a funeral or a memorial, writing a letter to the lost baby, releasing a balloon, right? And then as it relates to infertility, do you want to light a candle each month? There's no successful pregnancy, buying flowers each month, monthly dates with your partner, with yourself, writing letters to one's future self, right? What are ways you can use your gifts and create poems, cards, drawing as a way to express this grief. So it's not, again, disenfranchised, but you're holding in mind the way, ways to commemorate this grief and loss. So I would like for us to discuss a clinical tool that can facilitate discussions around attachment and enhance the therapeutic work, which is the adult attachment interview. This is a structured interview that can be used as an adjunct to therapy. It's typically recorded and transcribed. And, if one of the ways that, after that interview, you kind of go back and look where you watch it together with your patient, maybe not everything, but maybe excerpts, like things that maybe lingered in the patient mind about things that really resonated with them, right? And so what it does is it assesses attachment relationships during childhood, adolescence, and adulthood. And there are these different classification systems, right? Like secure, autonomous, dismissive, preoccupied, unresolved, or disorganized, right? So for individuals who are maybe classified as secure, maybe their narratives appear coherent, and it shows how much they value the attachment, right? With dismissive classification, right? It's sort of like you ask them a question about like what was their parenting experience like? Well, it was okay. I don't remember that, right? It's my parents are fine. Aren't all parents that way, right? For the preoccupied attachment style, we typically see is that the individuals give a lot of information. Sometimes that's not necessarily as substantiated by, the stories that they present. And sometimes the therapists can, feel quite overwhelmed by the amount of information that's offered. And then there's the unresolved or disorganized grief, these questions tend to, might show you if the individual has some unresolved grief there, right? So you do start seeing them speaking of the dead loved one as if they're alive. So the AI facilitates, the therapeutic alliance. And it can, like I mentioned, it can uncover traumatic experiences and other losses. It can identify a range of defensive processes. So what I mean by that, you start seeing things like they're idealizing the parent on the interview, but also like they're not, the examples that they're providing may not be the version of the parents that perhaps they hold in mind. It helps to identify angels in the nursery, which is proposed by Lieberman, who talks about like there are people in individuals' lives who are these positive adult figures. And again, that might be an uncle or a grandparent who was able to hold a safe and secure base for them. And lastly, it permits reflective functioning, which is an individual's ability to put themselves in the shoes of another. So maybe this is the first time they're really thinking about, well, maybe my mother experienced this, or maybe right? And so like it allows them to be able to be aware of their own states as well as others. So here are some questions from the AI. And let's see how much time we have. Okay, so I'll just sort of go through, like I included like, questions, about childhood. Like, can you please tell me what it was like, with your parents as a very small child? Or thinking back from as early as you can remember to the age of about 12, what are 5 adjectives or words or phrases that you would describe your relationship with your parent? And then, as it relates to current relationship, what is your relationship with your parents like as an adult? There are questions specific to grief and trauma, right? Did you experience the loss of a parent or a close loved one while you were young, or a sibling or a close family member? And then with trauma, right, have you had any other experiences which you would regard as potentially traumatic? I'd like you to pay attention to these 2 last questions, because like those questions I feel like really gives you a sense, especially for individuals who are struggling with infertility or pregnancy loss. You start wondering about like, how are they really thinking about this, right? So one question is, I'd like you to imagine that you have a 1-year-old child, and I wonder how you think you might respond in terms of feelings if you had to separate from this child. Do you think you would ever feel worried? And then the other one is, now I'd like you to continue to imagine that you have a 1-year-old child for just another minute. And this time, I'd like to ask, if you had 3 wishes for your child 20 years from now, what would they be? So, and then I'm thinking partly of the kind of future you might want to see for your imagined child. So Nicole, this is where I'm going to ask you to pause the recording for me. Attachment figures. So like they're yearning for support, but also worried, as chronically worried about being disappointed by the lack of availability of support figures. Sometimes you might see, again, like the somatic expression, so like that flushed face, the tense, sweaty, when discussing experiences of loss, and turning to attachment figures for support. As it relates to experiences of pregnancies after loss, they are dominated by pervasive pregnancy-related anxiety, as each loss is experienced as like another abandonment. And then, there might be negative internal working models, right? So like experiencing infertility as confirmation of unlovability and inadequacy. And then as it relates to the avoidant, like maybe there's a denial of having feelings related to past losses or towards infertility, and maybe also denying needing comfort and support from the other. The individual might be cut off from their emotions when asked about reproductive events, may provide weak, vague, or superficial responses to questions about miscarriage and infertility. Their body language, which is interesting because like it's, you think about telehealth and then actually being in the room with the individual, right? Their body language might be suggested that there is a denial of sadness and loss, so that might look like avoiding eye contact, crossing arms, like maybe if you're in the room with with the therapist, sort of like leaning away from the therapist. And then there is a reliance on defensive structures. So it might look like sort of like intellectualizing, right? Or maybe detaching from the experience. And so I want us to talk a little bit about what are some of the takeaways from today's presentation. And just sort of remind us to listen for reproductive stories. And some of these stories need to be told repeatedly. How did they come into this world? What were their sort of like ideas around, conception, and what did that look like? How did that shift over time by, infertility or pregnancy loss? So I want to factor in what the meaning of the loss, like what does that mean to them, as an individual? Does that mean something about their identity, who they are as a person? You also want to understand the full context of readiness and wish to take on a parenting responsibility, right? So somebody, late 20s versus somebody in their late 30s, does that look different or similar? I also want to listen for the intensity and the extent of the attachment to what is lost, recognizing, atypical versus normal grief reactions, right? And not pathologizing grief. Considering meaningful rituals to validate significance of the loss. Like what can you talk about with your the individuals in your therapy rooms about like how do you want to validate this loss or this experience, so that we can move away from the disenfranchised grief piece. Going back to reproductive trauma, to growth piece, right? Like, can you also hold space for what this experience is also doing for you individually, as in addition to what that experience of grief and loss might look like. The therapist paying attention to one's own countertransference, right? And what I mean by that is like, how are you reacting to what the patient is sharing? Therapists also have their own reproductive stories, right? Our clinicians have their own reproductive stories, providers, right? And so like, are you drawn to share your story? It's perfectly normal to be able to say something if you feel inclined to. And I think oftentimes individuals who experience these type of losses and grief, like because it's so incredibly isolating, knowing somebody else have gone through that can also be helpful. But do you notice that you're drawn to sharing a little bit more? And so like the patient is maybe taking care of you a little bit there, right? And so like paying attention to your own countertransference, and just like what's happening in the room room. And then lastly, I would say, you know, as it relates to vicarious trauma, listening to trauma. And the intensity of trauma, which is very common in pregnancy loss and infertility, can be quite intense and challenging even for the therapist. And so, you know, that might also contribute to vicarious trauma. So the therapist kind of feeling that trauma too. I read about the concept of liminal space, right? Like, can you allow, like, sure that the patient is sharing the traumatic experience, but can there be space for that material to sit, right? Rather than sort of like taking on too much of that. And then that's sort of certainly contributing to burnout, right? Also taking care of yourself, right? Finding ways to care for yourself as a provider in the room, especially as you're navigating these really incredibly painful stories. And then I just want to leave you with some resources that I used, that helped with this presentation, and also websites, resolve.org, specific to fertility-related information, books, podcasts, you name it, around, infertility. There's the American Society for Reproductive Medicine. There's also Postpartum Support International that offers support groups for pregnancy losses, fertility-related challenges, and even more. So with that, I'll stop here and see if anyone have any questions.
Wonderful. While people are thinking through questions, I just want to say that was amazing, Dr. Richards. Thank you so much for that presentation.